Hi, I'm Daniel O'Brien from the Physiotherapy Department at Auckland University of Technology.
Hi, I'm Kathy Morton and I'm from Arthritis New Zealand.
And today we're speaking with Professor Kim Bennell. Kim is a physiotherapist and researcher who has dedicated much of her career thus far to improving the management of hip and knee osteoarthritis. Kim is a professor of physiotherapy at the University of Melbourne, is a principal research fellow at the University's Centre for Health, Exercise and Sports Medicine. She's published over 300 peer-reviewed articles and is currently in New Zealand as a keynote speaker for this year's NZ New Zealand Manipulative Physiotherapy Association conference. Welcome, Kim, and thank you for participating in this podcast.
Thanks, it's great to be here to talk to you.
So for a first question, Kim, can you tell us a little bit about your background as a physiotherapist and what drew you to begin conducting research on osteoarthritis?
Well, I started off as a musculoskeletal physiotherapist working in private practice, and then I did a PhD looking at bone health actually in athletes. But we then, with some colleagues, Jenny McConnell from Sydney and Kay Crossley from Melbourne, we started to look at chronic knee pain, and from there it progressed into knee osteoarthritis because it's a major public health problem. And at that stage really, which was around about the early 1990s, there wasn't a lot of research in the area, particularly from physiotherapists, so we saw that there was a gap in evidence and something that we could sort of fill.
I know that you're speaking about a couple of projects this weekend. Would you be able to tell us a little bit more about those?
Yes, we've got a lot of research on the go at the moment, and a lot of our research has now shifted toward looking at sort of the biomechanics and so forth of treatments to really implementation research, where we're looking at how we can best integrate the evidence that we have for treatments into actual clinical practice and researching whether those methods are effective. So we've been looking at different models of service delivery, and one of the research projects that we conducted was to look at how we could remotely deliver biopsychosocial care so that all people in rural and remote areas and perhaps people who can't get out of their houses could better access treatment. And so what we did was we looked at physiotherapy prescribed exercise delivered via Skype, so people could have appointments with the physiotherapist via Skype in their own home. And so participants received 5 sessions with the physiotherapist via Skype, and also the treatment involved the patients accessing an online pain coping skills training program, which is a form of cognitive behavioural therapy. And so the patients were able to access those modules. There was 8 modules, and they'd complete them over 12 weeks, and they could do them in their own time and again in their own house. And we conducted a clinical trial where we looked at people with knee osteoarthritis. We randomised them into 2 groups, one group who received the package of treatment, and the control group who had access to educational material online. And what we found over 9 months was that there were significantly greater improvements in pain and function in the treatment group compared to the control group. And these improvements were what we would class as being very clinically significant and important. We also conducted qualitative research along the way with that, where we interviewed the patients and the physiotherapists to ask about their experience with the treatments. And what we found was that patients were very, very positive about the treatments. They really liked the fact that they could access it from their own homes and their workplaces. They didn't have to travel and have the expense of travelling. They really found it also, which I thought was very interestingly, they described it as being more personal. So that even though it wasn't face-to-face, they described it as being more personal because the physiotherapist was coming to them in their own home. They also felt, again, which was very interesting, they described it as a bit of a shift of power, in that they felt like they had more control and more power because the physiotherapist was coming to them and they weren't going to see the physiotherapist in their treatment rooms, which was really very interesting. From the physiotherapist perspective, a lot of them were firstly said that they were sceptical because they, as physiotherapists, we want to put our hands on things, and so they were a bit anxious about how it would be delivering physiotherapy and exercise when they couldn't touch the patient and be there in person. But they were actually very positive at the end, where they could see that in actual fact a lot of what they perhaps thought they needed to do, they didn't need to do, and that the results and the outcomes were very positive, and that they also found that the patients really enjoyed it. So the physios were very positive as well about that. So that's an important project, and one that we're now hoping that we can then put into practice. But there are barriers to that, around funding for physio that's not face-to-face, changing the culture of physiotherapists who believe that that they see themselves as placing hands on them, and so changing that. Also, it's a different way of delivery. So having training in how you deliver treatment in a different way.
You mentioned at the start of that around bringing in a biopsychosocial approach to the care. Now, obviously, that's something, or a term that's been bandied around for 40 years now. What was your interpretation, or the interpretation of the biopsychosocial approach that you gave to the therapists who were delivering the service, so that you were all on the same page and approaching it in the same way?
Sure. So this particular project, the physiotherapists were given some training in what the online pain coping skills program was about. But I think one thing in terms of being able to improve the service would be to have the physiotherapists better reinforce the skills that the patients were learning on their own in this pain coping skills program, because I think the physiotherapist could better help the patient incorporate those skills into, say, exercise and physical activity, reinforce what they're learning. And so I think that would be something that if we're going to improve it, we could give some training to the physios on how to do that. In a previous project that we did, we actually trained the physiotherapists to deliver the pain coping skills training. So they were the ones who underwent a lot of training, and they were the ones that delivered these skills. And so they were able to do that, as well as psychologists. We'd worked with a researcher who had previously only trained psychologists to do it, and he was very impressed with the standard of delivery of pain coping skills training that the physiotherapists could do. So I think physios have the capacity, and I think we should be addressing both aspects. We know that people with knee osteoarthritis have a lot of issues around psychological status. There's increased rates of depression and anxiety, and lack of self-efficacy, pain catastrophizing, and so forth. And all of those things, unless we address those, our treatments aren't going to be as effective. And in that other particular study where we did train the physiotherapists to deliver pain coping skills training, we found that the combination of exercise plus pain coping skills training was more effective than exercise alone. And so to me, the benefits of combining those are really positive. You
talked about some of the barriers that the clinicians had when they first came, or they were a little bit sceptical. Are there any myths from sort of your experience of working with clinicians that clinicians hold around osteoarthritis management that we really need to get out of the profession?
Yeah, I think there's some myths and misperceptions, and it's not just physios, it can be GPs and other health professionals, and also the patients themselves. And some of those common myths that we want to try and sort of change, and it's things around, firstly, how you describe osteoarthritis. So we used to describe it, and often people still do describe it, as wear and tear. And we've now sort of moved on with our thinking. We don't refer to it as that, and referring it to wear and tear isn't good from a patient perspective, because if you think something, you're told that the joint's worn out or it's worn away, you've got bone on bone, that's a really negative, sets up a very negative expectation in the patient's mind that there's nothing you can do. The joint's worn out, there's nothing you can do. So we don't use those words anymore to explain that. I think another misperception or a myth is that it's due to ageing. And yes, it is more common in people as they get older, but it's not caused by ageing. And if you think it's due to ageing, then as a patient, what you will think is, well, there's nothing I can do because I'm getting older, and so because I'm getting older it's only going to get worse. So again, that's a bit of a myth or a misperception. Another one is that exercise isn't effective for people who have more severe disease, say on x-ray, or more severe pain and function. Again, that's not correct, and the research has shown that exercise is effective for all people with osteoarthritis, irrespective of their age or their comorbidities or their level of x-ray dysfunction and so forth. And another one is that we need to have an x-ray to be able to manage the condition, and x-rays are now not recommended for clinically diagnosing OA. They don't correlate with symptoms well, they don't predict response to treatment, they don't predict how someone will change over time, and all they do actually is reinforce these myths, and x-rays and other imaging techniques such as MRI just lead to people being sent for inappropriate investigations and having inappropriate treatments like arthroscopy and joint replacement that they may not need.
Well, obviously that's one of the areas of waste that you would consider absolutely the hottest topic out. Are there any other areas of healthcare waste in osteoarthritis management in Australia that you would like to tell us about?
Yes. So as you've mentioned, so the X-ray and the imaging is a big one, and just interesting on that point. It's often it's not necessarily all the health professionals' faults, because oftentimes it's the patients who are coming in and are wanting an X-ray or an MRI, and so requesting that they have that. And so it puts the clinician in a difficult position, because you want to, that's your patient, you want to keep your patient, you want to keep them happy. And so, the easiest thing, particularly in a busy practice, is, just send them off for that, write the referral and send them off. So it takes a lot of time to get the patient on side in terms of explaining why imaging isn't needed, what that means. So we've looked at some of the reasons why people are wanting x-rays and what does it say in the literature, and that's one of them. Other things are around the person's confidence, in the clinician's confidence in making a diagnosis, and so that then can be upskilled. The clinicians need some more upskilling around being able to make a confident clinical diagnosis. As you said, the other area of waste in the healthcare system is arthroscopy. That's a big topic. So the number of arthroscopies, knee arthroscopies, has just increased over time. The clinical guidelines, and there's clinical guidelines from orthopaedic societies that now do not recommend arthroscopies for the management of OA pain. So in people who have pain due to osteoarthritis, also even for people who report sort of mechanical symptoms that we might think of, yes, they might have pain, but if they have clicking or those sort of catching symptoms, they should have an arthroscopy. And again, the research doesn't support that. So the clinical guidelines and the recommendations now not to have arthroscopy is based on very good randomised controlled trial evidence. A number of studies, there's probably now 6 or more, maybe even more, that randomise people with OA knee pain into an arthroscopy group, or a group that have either sham arthroscopy, so pretend arthroscopy, or good physiotherapy, conservative management. All of those studies really have not shown any superiority of arthroscopy compared with these other treatments, and we know that arthroscopy is associated with risks and costs, and so now that's why they're no longer recommended.
And I think one of the things that we hear a bit about too is the use of steroid injections. That is, people will say, well, I had a steroid injection not so long back, and that seemed to be okay.
Yeah.
And so how many can I have? Can I just keep on doing this? Or shall I put a bit of hyaluronic acid in there, or
So corticosteroid injections are obviously different from hyaluronic acid, which is a viscose supplement. So if I talk about corticosteroid injections, the evidence from a large number of studies now, and they've pulled all the results from those studies together into a meta-analysis, really show that they are more beneficial for pain relief compared with placebo in saline injections into the knee, but just in the short term. So, 2 weeks, 3 weeks, and they'll have a benefit at that time. There's been a recent study that's just come out where they looked at, over 2 years, a repeated injection every 3 months. And they wanted to look at what that effect had on pain, but also on knee cartilage and they looked at that using MRI. And so they took people who had knee osteoarthritis and synovitis, inflammation, because they thought that the injections would be more likely to be effective in that group. And what they found was that over the 2 years, there was no significant difference between the two groups in terms of pain, but there was actually significantly greater loss of cartilage with the injection group. So some evidence that really perhaps these repeated injections may not be good at a structural level. So I think now people are suggesting that, maybe just some one-off injection if the person's having a pain flare for whatever reason, they've twisted their knee and it's really, the pain is much greater than that, and just to settle it down, but not for it to be a treatment that you just go in and see that as your quick fix. I'll just go in and every few months have another injection, but there could actually be some harms from that, from the joints perspective over the longer term. Hyaluronic acid, which is a viscose supplement, is different. They're often they're costly. Often the injections, they can be relatively well tolerated, although they can have some adverse events. But there's a lot of controversy about whether or not they are effective. There's the problem of some of the trials being industry sponsored, and therefore the independence of the results from those sort of studies. And as I said, a lot of really debate in the literature, and if you look at what the clinical guidelines say, most of the clinical guidelines don't recommend viscose supplements at all for the management of OA. And again, I think it comes down to weighing up, if you're looking at all the different treatment options, it comes down to weighing up the benefits, the costs, and then also the cost of, if you're having those, what aren't you doing instead? And what you do, if you're going and having repeated injections and things, then you may not be taking responsibility and doing the lifestyle treatments like exercise, like weight loss, like trying, pain coping skills training and so forth. And so it kind of takes them into sort of passive treatments. So that's really the status at the moment in those treatments.
I think it was last year, fellow compatriot of yours, a surgeon, released a book, I think driven by frustration that the research wasn't, he's an orthopaedic surgeon, so Ian Harris, and it was released out of frustration that the message wasn't getting from the researchers to the surgeons to what they were doing with patients. Do you think that's still happening, that there's a block between researcher or research findings being implemented in clinical practice?
Definitely, and that we've got a lot of really good research, and we've got actually a lot of effective treatments for osteoarthritis, and there is a big gap between that and practice, and that's why we have our NHMRC Centre of Translational Research in musculoskeletal pain to address that very gap. And we need research around the translation, because you can translate something, and oftentimes this is what happens, is something is translated, and you may spend a lot of money translating something, but you still don't know whether that works. And so now there's a big science around translational research. And Ian Harris, the orthopaedic surgeon, I think he describes surgery as the ultimate placebo, doesn't he?
Does.
Yes.
And he makes a very good argument for it too.
That's right, because if you're having something that's very invasive and you've paid a lot of money for, you want to believe that is going to be effective. So yes, he does do that. I think to the point of this evidence practice gap, we call it, oftentimes we might try and rush into implementing something in practice, but what we've done, we're now doing a lot more research in this area, and I think what we need to do is to have a much better understanding first, and working with all the stakeholders, the different groups, the patients, the health insurers, the clinicians, the professional organisations, and working with them to identify what are the barriers and facilitators to uptaking that care in the context that you're working with. Because if you don't understand and have a good understanding of what those barriers and facilitators are, then you might be implementing something that's just not going to work, because that's not the reason that it's not being uptaken, for example. So you're making assumptions as to why something isn't working or why it isn't being implemented, and therefore you're not addressing the right aspects. So I think that's a really good start. Firstly is to have a good understanding of why not, and then to, based on that, picking the right intervention in terms of the right model of service delivery or the right interventions to address those barriers and facilitators, and then to evaluate the outcome.
So do you see osteoarthritis treatment changing in the next 5 to 7 years? And will research have a role in driving that change, do you think?
There is going to be a big change in the way we deliver care. So I think, the message around exercise being really important hasn't really changed over the last 5 years or 6 years. I remember talking here at the conference 6 years ago, and probably those messages haven't really changed. And I sort of had a look at what my research and what the talk I gave back then and the talk I gave now, and those messages around what seems to be effective, that really hasn't changed that much. But what has changed is all of this around how do we deliver better care, and what can we do to make it easier, and how can we address adherence with people with OA, and how can we better skill and train the clinicians to work with that, and as I said, how can we deliver the service in a different way. And that's why the example of delivering it via Skype or different ways, or online technologies and things. So I think that's where it will go. Hopefully there'll be more ability for us to work out who responds best to which treatments, because I think again the problem with the clinical trials is we've treated everyone as one big group, and we know that that's not right, that people with osteoarthritis are very different. They're very different from their age and their the reason they've developed in the first place. Some may have had it from playing sport, and others have developed for different reasons. Others have got more psychological issues, so they're very different, and yet we put them in a trial and we manage them all the same way, and then we find that the treatments are perhaps not as effective as we hope, and that's probably because there are different subgroups who will respond differently, and we haven't been able to work out from research yet, because we haven't done the research to answer that. So I think there'll be more research around that area, and then that will probably help us better direct, well, okay, this is probably going to work much better for you than this, so why don't you try this? I think that's going to be where it goes. I mean, obviously at the basic science level there's a lot of research trying to direct it at, can we grow cartilage in the dish, and 3D manufacture cartilage and cure it all together, cut out the bit and put in new cartilage. So there's a lot of research around that area, and maybe down the track, certainly not in the next, there's nothing like on the horizon that's going to happen, but down the track maybe.
And I suppose those sorts of things are really, really nice, and might be really, really nice for people in 10 years' time. They're not going to be cheap anytime soon, are they?
No.
We're not going to be able to deliver that for 300,000 New Zealanders in 10 years' time.
No, so it has to be the big public health message. And the thing is, it's those things that are really hard to change from a behaviour change perspective. It's weight loss. I mean, if we could answer that, we'd help diabetes and heart disease and osteoarthritis, so everything. So we all kind of need to band together. So we're not just talking about weight loss for OA, because most people with OA will have a whole range of comorbidities. So it is the collective of how we can all get together, and because everyone wants to have weight loss as part of their management. If we went to the diabetes conference, I'd all be sitting there having the same conversations, that exercise and weight loss are important, and how do we get people to exercise and lose weight.
Well, do you have 2 or 3 maybe take-home messages for clinicians listening to this podcast who find people with OA a little bit challenging to manage?
I think one of the things is to think about the language that you use, and to really try and engender a sense of optimism and hope for the patient, because oftentimes they've come in thinking that there's not much to be done, and they're going to have a joint replacement, and there's a sense of kind of hopelessness. So I think the words that you can choose, and the instruction about what OA is, and that not everyone progresses, and that there's a lot of variability, and people can improve. There's a lot of things that we can do, is one message that I'd give. The second message I would say is to really try and practice patient-centred care. We all sort of think we know about it, and we'd like to think we're practicing it, but it's actually quite hard to implement in practice. And And part of patient-centred care is that shared decision-making. And so shared decision-making means that you lay out on the table for the patient and you discuss, have a dialogue back and forwards about what are all the different options that patients can have. There's surgery and there's injections, as we've talked about, there's exercise, there's weight loss, and what are the evidence to support all these different treatments, and what are the pros and the cons, and what are the costs, and talking to them about what are their preferences, and then helping them to come up with decisions about what they would like to try and what you can offer them as well. So I think that's really important. And I think the third one is I wouldn't underestimate the power of education. And oftentimes, as we said, physios feel like we have to put our hands on patients. But to me, spending a lot of time checking that the patient understands and having that dialogue around the treatment and helping the patient to self-manage and explaining to them that they are the expert in their knee problem and that you'll be there to help them, and that you want them to self-manage, and to really try and define that self-management doesn't mean off you go, you're on your own. Self-management means that they are the expert, that there's lots of things that they can try. Sometimes it's trial and error, but there are things that they can try and that you'll be there to help them in this journey, and to know that it's actually not, acknowledge that it's difficult. A lot of the times it is difficult to stick with exercise or to try and make those healthy choices with weight, but people have these ups and downs, and you'll be there to help. Sorry, that's probably a long-winded answer to my 3 tips.
No, that's a great answer. Thank you very much. Kim, thank you very much for your time today. I sincerely enjoyed hearing what you have to say, and I'm sure all of those listening to the podcast will too.
Thank you.